Good morning, good afternoon, good evening, and good night to all our friends and colleagues who are joining us for this exciting webinar today. Our guest today is Dr. Rick Ferguson. Hi, Dr. Ferguson. It's a
Hello.
pleasure and honor to have you.
Thank you. Pleasure to be here.
Thank you. So I'm going to go ahead and read Dr. Ferguson's credential here, introducing. So Dr. Ferguson graduated from dental school at the University of Florida in 1993. He completed a general practice residency at the University of Miami-Jackson Memorial Hospital. Dr. Ferguson is an adjunct professor at the University of Florida College of Dentistry and has this distinction of being awarded diplomate status in the American Board of Oral Implantology, Implant Dentistry, International Congress of Oral Implantology, an associate fellowship in the American Academy of Implant Dentistry. He is also a member of Academy of General Dentistry. Dr. Ferguson lectures nationally and internationally on topics of implant dentistry, bone grafting, 3D printing. Uh, Doctors Katrine and Rick Ferguson founded an implant training program of their own called Implant Educators, which train doctors on comprehensive uh, implant training. Welcome, Dr. Ferguson.
Well, thank you for having me, Dr. Kayvon. So
Oh,
today, the topic on hand is 3D printing surgical guides in office. And, it's my pleasure to be here and share this information.
great having you, Doc. This is really exciting. So, I don't think anything about implant dentistry is simple, but, you're calling it simplifying complex dental implant placement with in-house 3D printing and, making it efficient, practical, and economical. I'm, very excited to hear uh, your webinar. So,
We could go ahead. Go ahead.
so uh, let me ask you some questions. So, when you say what inspired you, Doc? I mean, I've been to many of your lectures, by the way, and I enjoyed all of them. Very insightful. But what inspired you to start this 3D printing? How did you start this?
So what happened was back in 2013, I have been doing implants for over 20 years, and it became routine. However, there's always that level of unpredictability. We had started using surgical guides from
Right.
various laboratories, and that certainly improved our efficiency. I actually attended a meeting, the Florida Dental Congress meeting, and I saw a dentist place an implant using a surgical guide in about 10 minutes. And he had fabricated the surgical guide in his own office on a milling machine. And I was very excited about this. Here I was teaching implants, placing a lot of implants, doing lectures, and I was using surgical guides, but the idea of doing it in office really appealed to me. So it was a sponsored event. He did a live surgery in at this meeting, and the company that sponsored him had a booth. So I went over to the booth and I asked them, okay, I want to be able to do this. How can I incorporate this into my practice? And they showed me all the equipment that I needed to buy, and it came out to about $330,000.
Oh wow,
And it was a lot of money.
that's a
That's
lot of
one
money.
thing. But then, then you could only use it to place a single implant. You could only fabricate a guide on your milling machine to place a single implant. You couldn't do full arch. You couldn't do more than one implant. So it really didn't make sense to me. But I got intrigued with the idea, and I spent about 2 years researching 3D printing surgical guides, finding a lower cost way, a more efficient way to do it. And after about 2 years, we had enough information. We looked at various technologies, and we came up with a way to do it in office. And I didn't expect that it would the actual cost would be this low when I went on that journey. but actually we're able to do it now for less than about $20 a case, with an
Wow.
amazing turnaround time. We can actually design and fabricate a guide for next day surgery, and we've even done it for same day surgery. So that was really the inspiration. It was something that I felt was the next step in implant dentistry for us in our practice.
I see. So when you say that the guides cost about $20, what about other costs? What about the printer? And what about timing? So dentists are really, we're all busy, doing the surgery, and a lot of us don't have time to actually sit there. And what about what about that?
So I'll go through some of that in the slides, but you can get a 3D printer now at very low cost for, even $250 that can make an accurate surgical guide. As far as the time, to do a simple surgical guide, single tooth, let's say, I can plan that in 10 to 15 minutes in the software. Now, also, we do a lot of delegation of the actual printing in our office. So we have about 4 3D printers in our office. And as you said, your time, your doctor time is valuable. So it's important that whenever we think about incorporating technologies such as 3D printing or milling, which is another thing we're doing, you want to make sure that it's simple enough that your assistants can take some of the load from you.
Absolutely.
And your time is better spent maybe doing clinical treatment or planning cases. I think many of us are already planning cases. So the next evolution in that is actually to go to the surgical guide.
Amazing. Well, so now you're printing full arches guides, and and Doug, how easy is this to do? How is it really difficult to start doing this?
So the printing part of it is, once you get that under your belt, and there's a learning curve with everything, of course, right? But once you set up the printer and learn how to use it, it's like using any other technology. It becomes routine. Okay. There is some maintenance with the printers. Some printers are easier to use than others. And, I'll go through that in some of the slides. But the idea is that once it can become a routine thing. All right. The design process is difficult in that, again, it's a learning curve. And the more complex the case, for full arch case, for example, where we're designing not just a surgical guide, the drilling guide, a bone reduction guide, a stackable guide on top of that for the drilling guide, and then the temporary provisional prosthesis, right? That becomes more complex. So if you don't enjoy that kind of thing, the wonderful thing is that you can have a design service or a laboratory do that part, and then just 3D print in-house. Whether you're printing the surgical guide, a single tooth surgical guide, or a full arch guide, or a provisional prosthesis, that part of it sort of remains the same. The design process now, luckily, the laboratories have come on board to help out with the design. Personally, I like to design my own cases. It will take me anywhere from, like I said, 10 minutes for a single tooth. It might take me 2 hours to plan a full arch case with a bone reduction guide, drilling guide, and provisional prosthesis. But what it's doing is actually saving me chair time. I can do a case like that. The surgery should take less than an hour. What takes time now is the provisional aspect of it. And I'll go through some cases, but it's really saving you time and effort chairside. And what it's actually doing for me in a big way is improving our predictability. Okay. Many of us have the clinical experience, but again, we do encounter, stumbling blocks sometimes in surgery and have to change the way we do things. We've been able to reduce that significantly by using surgical guides that we are intimately involved with in the design process and printing process.
That's amazing. I mean, you're absolutely right. I think one of the most difficult and challenging part of the implant surgery is the restoration part, when you're going to restore. If you can design it right and you have the right tools, and it'll save you a lot of time. Well, thank you so much, Dr. Rick. So I'll let you go on with your slideshow, and pleasure to have you.
Well, thank you very much. Let me start the slideshow here. Get this going. Okay, can you see my slides, Doc?
Yes, yes, absolutely. We
Okay,
can see.
perfect. So the topic at hand today is simplifying complex dental implant placement with in-house 3D printed surgical guides. I think it's efficient, it's practical, certainly, and economical to do so. Now, a little bit more about me. As you said, we have a implant training program called Implant Educators Academy, which we're actually starting our 13th year with this program. We run it with the University of Florida at their clinic in Seminole, Florida, near Tampa. So if anybody's interested, we can bring any U.S. licensed dentist to this program, and they can do surgery and under our supervision. And we have a full lineup of speakers, experts in all the different aspects of dental implantology to train and give the didactic lectures. And then we also do our surgery. So we're able to do, these are actually surgeries from our clinic, our students, cases that our students are doing. Sinus grafts, simple implant placement, bone grafting procedures, and everything that we do with guided surgery. This is one of our groups that we graduated about 2 years ago. You can see we have the capability to bring in quite a few people and get them trained, having zero knowledge in implants, or a lot of people come to our courses who want to learn more advanced surgical procedures. We also offer other courses such as 3D printing courses, oral sedation, and so on. And we do have a single tooth course, which we typically run over the summer. We're going to be starting those soon. The thing, though, that I am probably most proud of is that my wife and I, Dr. Catherine Ferguson, who is a co-director at our implant continuum, we have a small private practice in a town named Davie, Florida, near Fort Lauderdale. And we have the technology such as a CBCT, intraoral scanning. We do milling and 3D printing. And we have the capability in our practice to do pretty much every type of case, simple to advanced, full arch reconstruction in our very small practice, actually. Now, in 2012, the American Association of Oral Maxillofacial Radiologists had a position paper that 3D imaging should be used for all dental implant planning. And the reality is most of us are using 3D planning, using CBCT to plan our implant cases today because of the advent of low enough cost CBCT machines. As a matter of fact, I'm doing a webinar coming up on July 22nd with Dr. Leah Al-Matni. She's an oral maxillofacial radiologist called Digital Implant Planning from Diagnosis to Implant Placement. And it will have the perspective of the oral radiologist as far as the diagnosis and being able to interpret CBCTs accurately and look for pathology and such. So that's something that some of you might be interested in joining as well. And that's a free webinar, July 22nd. If you want information on that, please email me. I'll send you the link to register. But as I said, many of us are using 3D planning. And it's great, but how do we transfer the plan to the patient? How do we go from virtual reality to reality? Because we're planning in virtual reality, and a lot of times we can lose direction. If you look at a case like this actually was a text I got from one of my students. It happened to be a Sunday. He was pondering this case that he had sent the patient out. You can read what he wrote to me here. That he sent the patient out to the oral surgeon for extraction. The oral surgeon went ahead and placed implants. And a few weeks later, the patient came back to the general dentist and said, I can't feel my jaw. And the dentist took a CBCT, and what he found was that, sure enough, the implants were impinging on the mandibular canal, and there was possibly some nerve damage there. So this case was planned. The surgeon did use a CBCT, but he didn't use a surgical guide. And that's what we run into from time to time, where what we think we're planning in the 3D CBCT image, we can't actually execute that accurately, because a lot of times we'll lose orientation, we'll lose direction. And doing freehand surgery is great, but you do need the guide to have the highest level of accuracy. And you can see in my cases, as I'll show you in a minute, the level of accuracy we can achieve with surgical guides and even printing them in-house. So that brings us, of course, to guided surgery. Why don't we do all of our cases with guides? Certainly there's a cost of the guide, which up until very recently, was somewhat expensive. The cost of the software initial startup costs were anywhere from $3,500 to $5,000 and beyond. And that was an obstacle for some of us to get into using surgical guides on a regular basis. And there's a lab time. Most labs will take a couple of weeks to turn around a guide, and that adds to the inconvenience of using a surgical guide. But now with in-house 3D printing, we can eliminate most of those issues. As a matter of fact, there is free software out there, somewhat free software out there that we're able to use. We happen to use Blue Sky Plan. It's free to use, completely free to use. And when you export the case to the 3D printer, then there's about a $15 charge per case. So very reasonable, low cost way to get into 3D printing. I mentioned about, with Dr. Kayvon just now, how I got into 3D printing. This is what it was actually going to cost at that meeting for me to use proprietary technology, all from one company. And what I highly recommend today is when you're buying your equipment, make sure that it's open platform. In other words, you can have an optical scanner or an intraoral scanner from one company and use it with a CBCT from another company. In other words, don't stay with a closed system, because that's certainly going to increase the cost of you getting into 3D printing and surgical guides. I have a saying I like, that if you aren't at the table, you're probably on the menu. And what happens with technology in our practices is that it eats up a lot of our profits, because we make purchases based on emotion for things that we don't understand. Many of us don't truly understand the technology. When we go to a meeting, we see the shiny machines and the bells and the whistles, and we get drawn into that because it's an emotional purchase. And I think it's incumbent on us, before we spend money on these technologies, to really understand what we're getting for our purchase. Okay. We do have intraoral scans and intraoral scanners and CBCT, and that's really the best way, the easiest way to get into designing cases, not just for surgical guides. We use it for clear aligners. We use it for prosthetics as well. And we also have courses on using 3D printers for those technologies. But in surgical guides, it all starts with a CBCT and then an intraoral scan, and merging the two together. I have a workflow here that I've come up with, where we can take intraoral scans, merge them to the jaw scan from the CBCT. We also have the ability, believe it or not, to scan impressions in the CBCT, or scan stone models in the CBCT, and bring those in as well. And there are times when we'll want to do that, as I'll explain later on. We merge those images together, what we call our data sets, design and plan our case in software, and then export that out to the 3D printer. So it's really about merging these technologies and being able to use the different techniques to design a case and export. Now, one of the things that I did early in 2016 was I actually figured out a way to scan an impression and invert the image. And this is actually very useful for cases where you have a lot of X-ray scatter or beam hardening in your CBCT. Even if you have an intraoral scan of that patient, you can't really merge the images together, because you have this shrapnel-like appearance on your CBCT image, and it's hard to merge. So we actually will use a scan appliance taken from a PVS impression, and I figured out a way to invert that image using free software. I actually posted that on YouTube in 2016, and it got coined the Ferguson digital pour. And later on, Blue Sky actually added that as a part of their workflow in their software. So I'm proud to have made that one little contribution to surgical guides and implant.
Rick, sorry to bother you.
Yeah.
to interrupt you, we're having a little difficulty seeing all your slides there. Maybe you can zoom less in your slide, or zoom out a little bit.
I don't know how I would do that. Can you see my cursor here as I move across?
No, not seeing your cursor.
Okay. I have a slide up. It says, look for open platform systems.
No, we're seeing the digitizing the patient. That's what we're seeing right now.
Yes, that's the one. Okay.
Okay.
All right.
But some of your slides are cut out at the side. We're not seeing the full picture.
Let's see. Slide 2. I might need some technical help here.
Let's see.
Oh, I see what's going on. Okay. Let me close this. And then I will share the screen again. Can you see it now? Okay.
We're not. Yeah.
When I tried to share the screen, I'm closing. View your entire screen. Okay, let's try this. Can you see my entire screen now?
We're not seeing. Are you sharing the screen yet?
I'm trying. Can you see my screen now?
Yes.
Okay, how about now? Is that better?
Yeah, so it gets cut out. I'm not sure. Are you playing it? Are you playing the slideshow?
Yes, I am.
Yeah, maybe we can just not.
I think the problem is on your end because I'm seeing my slides.
Yeah, no, now we can see all of it. But once you hit play,
okay.
That's
How
better.
about if I do this? Is that better?
Yes, perfect. Perfect.
Okay, that's not how it's supposed to run, but I guess we'll have to do it this way. How about now?
Yes. Perfect.
Is that good?
Yes, that's great. Thank you.
Okay, all right. All right, sorry about that. So anyway, as I was saying, back in 2016, we figured out a way to take a VPS impression, scan it in the CBCT, and merge it with the jaw scan of the CBC from the other CBCT. So luckily, the CBCT manufacturers have stepped up their game, and they have incorporated workflows with their machines, such as this is a machine I have, the CareStream 8100. We can actually scan a denture, we can scan a stone model, we can scan and get a nice model from that. We can scan an impression, and the software will actually invert that impression as well. Okay. Basically, what this is capturing the data sets that we need to do our workflows. And there's even a way, if you don't have an intraoral scanner, to scan stone models or impressions and bring them in, scan them all at the same time with a byte registration, and bring them into the software and slice out the 3 images. And that will give you what would be basically what you'd be getting from intraoral scanner. Okay. We have a course on this. In one day, we teach surgical guides in 3D printing. And in that course, there are 4 workflows that I've worked out for the various types of cases that you will see. First of all, there's a tooth-supported guide, which works well for partially edentulous patients. There's the impression inversion technique, which is one that we use for dentists that don't have an intraoral scanner, which is basically what I just showed you on the previous slides, using an impression or a stone model and scanning those in a CBCT, and then you have the information, basically what you would get from an intraoral scanner. Workflow number 3 is if you have a patient with a lot of metal crowns or zirconia crowns where you can't get a good CBCT scan of the teeth, you can use a scan appliance, and we use an impression as a scan appliance, and that's basically the end result of that digital pore technique I mentioned earlier. And then, of course, there's the fully edentulous patient where we use a denture with fiducial markers and then merge that to the DICOM. So in our course, we go through all these different scenarios and give you all the different workflows. This is all for the planning. Now, if you're going to use a laboratory, you're still going to need to do the design for you. You're still going to need to do all of these different data acquisition methods, but the planning, of course, will be outsourced to a laboratory, right? And that brings us to, once we've planned everything and now we're ready to export, it brings us to 3D printers. There are various 3D printers on the market, some from dental manufacturers, such as the NextDent 5100 printer, which is an excellent printer, very, very fast, high-speed printer. Printer like this, you can see the platform size is about 124 by 70 by 196. That's the build volume. Resolution is 65 micron. A printer like that will run you about $12,000, which is not actually that expensive in the world of good quality 3D printers. This uses a technology called DLP, or digital light processing, which is basically like LCD, LED projector, LCD projector that you use in presentations. It has a projector inside the machine that that is actually creating the layers in the resin. This is a liquid resin printer. Another similar printer is the Sega Max or Max X or Max Pro, which again is now a very popular printer in dentistry. Again, this printer has a smaller build size, 67 micron resolution, and it's going to run you about $11,000. Those are very reliable printers that come from a dental dealer. You'll get support with that, but also keep in mind that there is going to be ongoing costs with those printers as well. Okay. Now, this is what you see on the screen here is the evolution in our practice of what we consider low-cost 3D printers that not necessarily were made for dentistry, but ones that we adopted throughout the last 4 or 5 years in our practice. And it's interesting because, you know, we started off with a $1,500 printer, which uses a technology called FDM, which is basically like a hot glue gun, a miniature hot glue gun, melting plastic and creating layers of material to build up the surgical guide. Then we went to a resin printer, the Form Labs printers, and eventually we transitioned to the Form 3B, which is the one that you see for about $5,000. We have a couple of those in our practice now. We use those when we're doing high volume printing, such as clear aligners. But the printers that you see on the bottom here range from $300 to $800 to $1,800. Those are really the ones we're using for surgical guides because they're actually faster, and because of the lower cost, we can have a dedicated printer just to print surgical guides or just to print the provisional. You know, so you don't have to switch resin tanks between prints. So that's one of the things that you can do with these lower cost 3D printers. And I have a Facebook group with about 8,500 members worldwide where we do some support on these lower costs, so, you know, quote unquote non-dental printers, because when you buy a printer for $300 or $250, you know, you're not going to get a dental dealer behind you to support that. So I actually started a free Facebook group where we work out resin settings and help people out with their 3D printing. As a matter of fact, the Frozen Sonic Mini is one of my favorite printers right now. You can see the build platform on there, 67.8 by 120 by 120, 62 micron resolution, which is actually very similar to the Sega printer. And this printer only costs $250. You can buy it on Amazon right now for about $250. The big brother to that is a little bit more robust version of that printer, but the same resolution and build platform size, which is the regular Sonic. That will run about $1,800. And then the Form 3B, which again I said we use for volume printing when we're doing aligner models, as you can see on the platform there. There are a bunch of aligner models. That will run you with the whole dental package and a 1-year pro dental service plan for about $5,000. So if you're doing volume, I would highly recommend a Form 3B. But for doing single surgical guides, you can start off with a Sonic Mini. The beauty also of the Formlab system is that it has the best ease of use of any printer out there on the market. And because of that, it's a truly delegable printer that you can delegate to your assistants to do most of the work with it. Okay, these are some of the things that we print with the various printers. If you ask me which printer I use to print these models or these appliances, I really couldn't tell you, because we use the printers interchangeably. That $250 printer will print any of these models or appliances that you see on the screen here. So will the more expensive Form 3B or the Asiga or the NextDent 5100. So, it's really about what you want in your practice as far as ease of use, whether you need a dental dealer to support you with a particular product or not. I think it's very easy to manage that little Sonic Mini $250 printer to make surgical guides. So you print your surgical guide. You're going to have a metal sleeve for most implant systems out there. And the parameters for printing what we call a guide tube, which is what the sleeve fits into, is going to vary by your implant manufacturer, by the surgical kit you're using. And again, we cover all of that in our online course. So let's look at a case. This is a case where I could show you a simple implant placement, and that's sort of easy to do now on an edentulous site. But let's look at a couple of cases where it's a little bit more complex than just a simple, straightforward case. This is Rhonda. She's 59 years old. She presents with a failing tooth number 8, which had a fracture, previously treated root canal, post and core, and had a fracture. She had some purulent discharge coming out of the lingual or palatal area of the socket around the tooth. And in her case, we decided, because there was enough remaining tooth structure that we felt was salvageable, to do a PET case, a partial extraction therapy or socket shield, which is well documented in the literature now. So if you look at the CBCT image, you can see here that the post space was prepared palatally, not directly down into the canal, and that probably led to the fracture. And so that left us with actually enough bulk of root structure on the facial so that we could do a partial extraction case. So we took our image on our Carestream 8100, brought it into the software, designed a surgical guide for this case so we could place the implant, but yet save a part of the tooth, that shield part of the tooth, out to the facial. So this is what the case looked like planned. You can see we have about 2 millimeters of space to the facial of the implant. That's going to allow us to create about a millimeter of the socket shield and leave that in place. And this is how we designed the surgical guide. It was designed basically like a simple single tooth case. You can see here on the screen how the implant is going to go in and engage bone apical to the socket, so that we have good initial stability of the implant. So clinically, we're going to go to the patient. We anesthetize the patient. We section off the existing crown and tooth. We'll go ahead and section the root that's remaining, and we have special burrs that we use to go in and remove the apical part of that tooth and leave just the shield part of it, about a 1 millimeter thickness of shield out to the facial. And then we'll use our surgical guide to drill the site and place the implant. And this is a post-op, immediate post-op of the implant in place. You can see we haven't even put a cover screw or a healing collar on. But you can clearly see the shield that remains. We did graft around the implant with some allograft. And you can see that there's a space of about a millimeter between the facial aspect of the implant and the shield, so that we have bone that's going to grow in and totally encapsulate and osseointegrate that implant. So that's the level of accuracy we can get with our guided surgery, even using an in-office guide, which in this case I actually printed on one of the low-cost printers. Now we do use an Ostel meter to test the stability of the implant, and because the stability was not enough for us to immediately load the case, we decided to place a custom healing collar, which I made from just a stock temporary abutment and flowable composite. We added in some PRF, plugs of platelet-rich fibrin using the sewn poncho technique from Dr. Dong-Suk Seon from South Korea, and packed that material in around the customized healing collar to create a biologic seal. This is what it looked like immediately after placement. So this is how the patient goes home. We'll have some temporary appliance for her to wear. In this case, she wore an Essex type appliance. This is a week post-op. You can see how nicely the tissue is healing. It's actually grown in around the custom healing collar. And this is at 5 months out after we have uncovered. We went back and took out the custom healing collar after the osseointegration process has occurred. Took our standard impressions and had a customized abutment, in this case zirconia with a tie base. And here is the final restoration. This picture actually I just took last week. This is 5 months after the final restoration was placed. This is an Emax crown cemented onto that zirconia abutment. And you can see that the aesthetics are basically what the patient had before, except I think the character of the crown itself is actually better, as you can see in the before and after. Look at the tissue profile around that tooth number 8, how it virtually is the same as if the tooth was untouched. Yet most of the tooth was extracted, an implant was placed, customized abutment, and then a characterized crown. So you can see the level of accuracy that we can get with in-house surgical guides using modern techniques such as partial extraction therapy and combining these technologies. So that's a single tooth case, basically the best that we have to offer to patients today with implantology. Okay. One of my favorite ways to plan an implant case for full arch is in the Blue Sky plan. We have a one-click denture guide. This is actually one of the workflows that we use and teach in the course. And that brings us to a patient like Kathy. Kathy is 78 years old. She had terminal dentition, a lot of infections going on, and we decided we're going to do full upper and lower reconstruction on her. Now, because of some of the medical issues that she had, we decided to stage her case. So we did edentulate her, and that didn't make her very happy, obviously, but we did edentulate her. And as you can see from where we started, and we went ahead and did a full arch scan using a dual scan protocol with fiducial markers on the dentures, upper and lower. She insisted that she wanted to keep some of those lower teeth to hold a partial denture in while we were doing this treatment. So we obliged her. You'll see how we treated the upper and lower differently. On the upper, we did a standard dual arch scan where we scanned the patient with the denture in the mouth, then scanned the denture by itself, developed a treatment plan from that. This is a denture with the fiducial markers. Planned out the case in the Blue Sky Plan software. And once we planned where the implants were, there's a one-click button to convert the scanned appliance into a surgical guide with the guide tube holes and fixation pins. So this is the printed surgical guide designed basically from the denture with one click. So when you asked me earlier about complexity of different guides, this case actually, once the implants are planned, it's very easy to design the guide in this particular situation because the software already knows the volume and dimensions of the denture, and that's what you're creating the guide from. So we're using that to drill and place the implants. This is actually an immediate post-op photo after the implants were placed. No flap was done, no tissue punch, just right through the tissue to place the 6 implants in this case. Here's an immediate post-op x-ray of where the implants ended up. And this is where we plan them to be, because we know we're going to go back later and do bone reduction at second stage to get to those implants. On the lower, we did what we call a sequential guide. Now, sequential guide is where we plan the case to be both soft tissue and, both tooth supported and implant supported. So the initial guide was actually tooth supported. We'll make 2 guides in this particular case. You can make as many guides as you want, but what we're doing is a sequential extraction. In this case, we used the first guide to place the first 3 implants, using the teeth on one side as support, the soft tissue on the other side as support also, and fixation pins. Once those implants are placed, we'll create a second guide, where the second guide will actually be attached to the previously placed implants. And then that will give us the security of the fixation as well, using fixation pins also. So these are the 2 guides. This is what we call a sequential guide. So you use one guide to place the first 3 implants, the second guide to place the additional 2 implants after you extract the teeth. And then that second guide will be attached to the first 3 implants that were placed. So here's what it looks like clinically. We'll use that first guide to drill and put in the first 3 implants. And in this case, we did do the case with a flap. Then the second guide will be used to place the additional 2 implants. And this is what it looked like immediately after the implants were placed. In this case, we're placing 5 implants for full arch lower reconstruction. And again, we're using platelet-rich fibrin, using the sewn poncho technique. And this, here we are with our 5 implants that are going to integrate, and then we can use them. In this case, we did not load immediately, but it is possible for you to do immediate load, as you'll see on the next case I'm going to show. Once these implants are integrated, we go back and do our uncovery. This is a maxilla. We printed a 3D provisional. On our 3D printer, we printed a temporary or provisional fixed hybrid, characterized it using pink composite. We used the system from Anaxdent, the Anaxgum composite materials. They come in different shades, and actually we talked about delegation earlier. My assistants actually do this part. They will print the provisional and then do the staining and the characterization using the Anaxgum materials, and basically finish the product, and then it's ready to be placed. So we went ahead here and made upper and lower 3D printed provisionals. This was done with NextDent surgical guide resin. It's an FDA cleared resin. You should always make sure you use FDA cleared resins for anything that's going in the mouth. We use NextDent. Typically, we're using NextDent surgical guide resin or Formlab surgical guide resin, and NextDent it's the NextDent multi-felt hybrid composite resin. Formlabs actually just came out with a very nice temporary resin that will soon be available in the US for doing these as well, which I think will be a little bit stronger than the NextDent product. But so far, we've had very good luck with the NextDent materials. The key to this, to making these provisionals so that they'll last, especially with the hybrids, is to make sure that there's at least 4 millimeters around any holes in the appliance, and also minimize cantilevers. In the provisional phase, we will basically eliminate cantilevers so that there's less risk of fracture, especially in your patients that are parafunctioners. So these are the provisionals in place. And once you've verified that the aesthetics and the phonetics and the form and fit and function are all good, we can then actually scan these with our intraoral scanner and send this to the laboratory. And the laboratory will use design software. We're using Exocad as our design software to make the final zirconia hybrid appliance. So this is the final zirconia hybrid appliance, basically copied from the temporary or the provision that we had designed and 3D printed. And here's the upper, here's the lower. And this is what it looks like, characterized, finished, ready to go. These are the appliances in place. So we took the patient from a terminal dentition, very crooked smile, to this was her final result. You can see really a very nice result for this nice lady. And we took her from not smiling to smiling, so that's always the best thing in the dental practice. And you can see the before and after here. So using surgical guides, having the idea of where the teeth are going to end up before we even touch the patient, because we're doing everything from a prosthetic workup, really makes the case go smoothly and efficiently. Okay. Here's one of my first cases, actually, where we did a full arch using a printed provisional prosthesis. So this is Ernie. Ernie is actually fairly young to be fully edentulous, but he had periodontal disease. He was diabetic, lost his teeth very early. And we did edentulate him and start with basically a perfect set of dentures as our guide for our final goal in mind as far as what we're going to try to achieve with our implants. So this was a lower. Again, we're using the denture, one-click denture technique to create not just the surgical guide, as you can see in the plan here, but also the provisional, because we're using the denture that was scanned as a model to create and 3D print the provisional. So the provisional was printed with NextDent provisional material. This is a NextDent, again, MFH composite resin. It was printed on our, I believe at the time we were using the Photon printer, which is another low cost, about $300 printer. And we did try it in before we started the procedure to make sure that the occlusion and the bite was good. Then we went to the surgical guide, which both of these appliances are very similar as far as the design, because they're both created from a scan of the denture. We will place the surgical guide in, fixate it using the pins, and again here we're actually checking the bite and make sure that the surgical guide is seated properly. Use that surgical guide to place the 6 implants in this case. You can see they came out nice and parallel. And then we took our provisional and did a pickup in the mouth. You can see even the provisional is indexed using the fixation pins, which gives us the bite so that even when we fixate it, when the patient opens, we can then inject the material with the patient open and have the appliance indexed to the telescopic copings. So once that's done, we hand that over to our assistant. They usually takes them about 45 minutes to finish the appliance, basically cutting back the flanges, adding the characterization, filling in any voids, using the same 3D printable resin, curing it with a handheld light curing unit, a UV light curing unit. So this is, again, something that's very efficient to do because these are light curable resins. So you don't have to wait for them to cure. And this is the provisional secured to the implants the day of the surgery. So basically, teeth in a day, all on 6, and the patient goes home with fixed teeth instead of a removable appliance in one appointment. This is a post-op x-ray of the final. And what's really nice using 3D technology, we can overlay. The white is where the implants ended up. The red is where we had actually planned them. So we can overlay the planned position of the implants with the final position of the implants and check the accuracy of our techniques. And you can see here they're pretty much spot on. And we do this routinely with our cases. And it's a very satisfying feeling to know that, what the time that you spent planning out the case came to fruition. So we'll finish up with this case. This is John, 78 years old. Now he had a fully edentulous lower. He had some missing teeth on the upper. He had a bridge that was failing. And we decided he wanted the lower done first. So we went ahead with the lower because he was wearing a full denture. And in this case, we did a bone reduction guide and a stackable guide with a 3D printed provisional. So you'll see the plan here. This case is a little bit more challenging to plan. This type of case usually takes me a couple hours of working in the software to plan. But again, this is something you can delegate. But basically what we're doing is creating a 3D model of the bone. On that 3D model, we'll create a bone reduction guide. And in this case, we're placing 5 implants. On top of that bone reduction guide, we'll create a stackable drilling guide. So you basically are going to open up the tissue, position your bone reduction guide, use that bone reduction guide to cut the bone down to the level that you want to be able to place the implants. Without taking out the bone reduction guide, you stack a second guide on top of that bone reduction guide, which increases your efficiency. Use that to drill and place the implants. And then, because again, we're using the denture as a guide for the implant positions and as a guide to design the provisional, there really is no design of the provisional. As long as the denture is accurate and has the proper contours and positions of the teeth, you can basically just scan it using techniques with fiducial markers. It's already aligned to the jaw, and then we can print that as our provisionals. In this case, I printed it on the Photon printer, which was, again, the same low-cost 3D printer that you can buy. I think they're available on Amazon as well. And this is how it's basically nested in the software for printing. So this is a case, overall view of the case of where the implants are going to go. You can see that the 2 distal implants are placed at a 17-degree angle to avoid the mental frame and yet increase our anterior-posterior spread. These are the 2 guides as they came out of the printer. You can see this is the drilling guide. Here's what it looks like on a model. You can actually print models and have them to evaluate the case prior to, and familiarize yourself with the surgery prior to doing the surgery. This is the bone reduction guide on the model. So here we go clinically now. We first trying the provisional. That's one of the first things we always do to make sure that the provisional was done properly, that the occlusion is correct. We'll flap the case, position our bone reduction guide, use our burrs to cut the bone down to the level of the bone reduction guide. Once the bone is reduced, the drilling guide will fit on top of this bone reduction guide. If you don't reduce the bone properly, if you don't reduce the bone, the drilling guide will not fit because it's actually created on a model of the reduced bone. So we place the drilling guide on top of the bone reduction guide and then drill and place our implants. And with the system we use, we'll actually place the implants through the guide, is what you see we're doing here. With this particular system, this happens to be BioHorizons, their guided surgery kit, which allows you to place the implants through the guide as well, which helps to increase the accuracy of the positioning of the implants. So here, all of our implants placed. We then attach our multi-unit abutments. The 2 distal ones are 17-degree angle multi-units to correct for the angulation, so that brings everything nice and parallel. We place our telescopic copings. We'll use some rubber dam over those and then place our provisional. And you can see in this case, we actually added injection holes so that we could keep the patient biting on the provisional while we do the pickup. So we inject the pickup material. And because this provisional is printed from a composite material, we can actually use materials that we already have in our office. In this case, this is Luxatemp. We use Luxatemp to do the pickup. It's a self-cured temporary composite material. So we'll inject the Luxatemp. And then once that's picked up, we hand it over to our assistant. And you can see here, they finish it very nicely for us. The Anaxgum company, which makes Anaxgum, they have a nice technique manual written by Christian Coachman on how to do the characterization of these provisionals. I actually got that, came with the kit. It's a nice booklet. You can actually download it from their website as well, anaxdentusa.com. And I basically handed that to our assistants and said, guys, figure out how to use this material. And, you know, as you can probably figure out by now, our assistants are tasked with a lot of jobs that other assistants might not be doing, but we make sure that we train them properly, and they're very progressive in that way. So they figured out how to use these materials to create the characterizations, and actually they quite enjoy it because you know, it brings out the artistic sense in them. So here's immediately loading of these 5 implants for John. Um, you can see here, this is now a 2-day post-op. We had him come back in just to illustrate how nice and clean these surgeries are. He's healing extremely well. This is as I said, a 2-day post-op. The swelling has almost had no swelling. That's one of the nice things about doing these full arch cases when you're efficient, because you're reducing your surgical time, so there's less trauma to the patient, less swelling, less inflammation, and they do extremely well with these fixed prosthetics. This is the final case restored after about, I actually just restored this case because we were shut down because of COVID for about 3 months. So this is actually overdue. We took about 6 or 8 months. We'll typically go back in 5 months to finish these cases, but this one took us a little bit longer. I think it took us about 8 months to finish. But you can see the results here, not just clinically. You have the fixed zirconia hybrid, and you can see the final x-ray, good bone levels on the implants, and that's how we do these types of cases. So you've seen now single tooth and full arch cases. We are able to do all of these cases very efficiently in our practice because of 3D printing. I will leave with some information if you want to learn more about using some of these low-cost printers. This is our Facebook page. It's free to join. We do give a lot of help. There's a community of dentists and laboratory technicians from all around the world. If you buy one of these low-cost 3D printers, I have no financial interest in any of them. You can buy them directly off of Amazon. And if you need help with any of the profiles for the different resins and such, join this page, and we're happy to help you out get started with 3D printing in your office. If you want to take our course on design of surgical guides and learn all the different workflows for the different types of cases, the four major ones, learn how to do the restorative 3D printing, or learn clear aligners, go to digitaleducators.com. It's a 3-day course, but you can only you only have to register for the day that you're interested in. The first day is on restorative 3D printing. The second day is on surgical guides, and then the third day is clear aligners. So go to digitaleducators.com, click on the registration link. It's now a online streaming course. The next date is August 7th through the 9th. August 7th would be restorative 3D printing. August 8th would be the surgical guide day, and then August 9th would be clear aligners. So you have all the information you need there. And then if you want to learn more about placing implants, or want to up your game with your implant placement, learn more advanced surgical techniques, or learn some of these digital techniques, because all of the cases we do in our continuum, which again, all of the cases are done by the students in the continuum. It's a 6-month continuum in Florida. We're starting in November. All of the cases are done using CBCT technology and 3D printing as well. All right. So you have all the information you need to contact me as well. I'll give you my email in a minute. I just want to leave you with this quote. Everyone wants to be on the cutting edge, but only the ones who know where that is. The ones who know where that is are the ones who have fallen off of it. I haven't shown you what it took to get to this point in our practice, but I can keep you from avoiding those mistakes, because we are willing to share everything we've learned and what we've done to refine our processes and our techniques over the last 5 years using 3D printing in our practice. Here's my email address and how to reach us on the web as well. I want to thank again Dr. Kayvon and Global Summits for allowing me to present. And I will now end. And if there are any questions, Dr. Kayvon, I'll be happy to answer them.
Yeah, Rick, yeah, what a beautiful presentation. Yeah, I love the accuracy that you show with these surgical guides. I mean, everyone's doing surgery knows that a little mistake can throw your whole case out. And so, beautiful results. Rick, we had a couple of questions. One of the viewers asked if how do you fix your stacking guide? You're basically, how do you fix your drilling guide to your after the bone reduction, right? How do you fix that?
That's an excellent question. So I experimented with different techniques of attaching the guides together, right? Some systems have a lock and key, some have slots. I don't know if you noticed there, but we had these little indentations in the guides. But what I ended up coming to was the conclusion that you really don't need a lot of fixation of the two guides together. If you notice that the drilling guide wrapped around the guide tubes on the bone reduction guide, I found that if you have the fixation pins in the front with the tubes from the fixation pins, that will give you at least 3 points. You really need a 3-point fixation, okay? And then in the posterior, I don't know if you noticed, but we cut the bone reduction guide at an angle so that it's sort of, the stacking drilling guide sort of slots into it. And by holding those together, right, it, to me, works better than even having like a lock and key system, because I found those clumsy working in the mouth during surgery with the blood and the saliva and the tongue and everything, and I've even had those parts break off. So I found that as a clinician, to increase my speed, I did away with those techniques and I only hold it in place. My assistants are very good at that as well. They know that they have to hold the guides in place. And that actually, whatever type of your guide you're using, whether it's a stackable guide or a single tooth guide, my assistants are trained to make sure that the guide does not move. And that is key to the accuracy of your surgery as well. So I hope that answers the question.
Absolutely. So it's not like a lock and key, it's more like a friction type, right? It's more like a friction type. And if you don't have enough reduction, obviously you cannot fit it. So you have to have enough reduction to place it on there. Great.
Yes, that's key. You do need to do proper reduction.
Yes. Thank you. So Rick, one more question. So if somebody was just to start, I know there was a lot of information here, and I'm sure there's a lot of doctors who are already doing this, or they're in the middle or they haven't started. But let's talk about the ones that haven't started. And if there was one advice you would give to someone who wanted to start doing this, what would you recommend? What would your recommendation? Would you recommend them to buy a 3D printer from eBay, or would you recommend them to actually do a good investment and buy some that they can use for other things in their practice?
So I find that a lot of my students today go through that evolution. With any technology, you want to make sure that it fits your practice. Okay? Right. My recommendation is actually start with a low-cost 3D printer. All right. It's not, I wouldn't get one on eBay, but certainly Amazon. Amazon has a good return policy.
Okay, good.
So that helps. But really, a $250 investment is not a lot. So I would recommend you start there, but I would recommend you take a course. Now, of course, I'm biased. We've worked out all the complications. We've made it as simple as it can be. But also, you have to think about this. It's going to take some time. You do need to put some time into it, right? Yeah. And I always recommend spending a couple of times with no distractions. That means get off Facebook, ignore your family, That's a joke I tell during my lecture sometimes. But you have to ignore and really focus to learn this stuff. But once you do it, it becomes like anything else. It becomes automatic. When I sit down to plan a case or I work up a case for a surgical guide, it's completely automatic at this point. There is a learning curve with everything. But to answer your question more succinctly, my recommendation is to get started now, right? Because unless you're planning to retire in the next year or so, right, I would say this is going to be something you're going to be doing at some point. All right.
It's the future. It's the future.
It's the future for a lot of us. For us in our practice, it's actually the present.
It's the present.
I am actually, quite honored to be on the cutting edge with this. Okay.
It's amazing. It's amazing. Yeah, it's amazing. Yeah. I've done a lot of guided surgery, and again, like you said, it's a learning curve. Of course, we don't use a 3D printer in the office, but it's very important to be involved in the process of designing your own, because I've done cases where I did not have time to get involved, and when you flap those or when you look at those, a lot of times you could be making mistakes. So it's very important to actually not just give it to a lab and be involved in designing your case. So the education in learning this is a lot more important than just the printer wise, right? So knowing what you're doing. Yeah.
Absolutely. People get focused on the printing part of it, but really that's just another tool, all right?
Right.
You're not going to discount what you've learned in the past on guided surgery or even non-guided surgery. We're still using the same principles that we're using when we're doing freehand surgery. Okay.
Absolutely. Well, thank you very much, Rick. Dr. Ferguson, really appreciate it. It's a pleasure having you, and hopefully we can all. You left all your information, so we can all contact you and get some more information and take your courses.
Thank you again, Dr. Javed, and it was my pleasure, and thanks for hosting this.
I appreciate it, Doctor. Thank you.
Goodbye, everybody. Thank you.
Bye-bye. Bye-bye.